In this video, I'll be going into obsessive-compulsive disorder. This is a disorder I know a lot about, and I don't believe anyone will have covered OCD on a media platform to this level. I aim to go into everything: the psychiatric perspective of proposed causes, treatments, and the up-to-date research on new and promising treatments, as well as the insightful perspectives that psychological and philosophical inquiry offer. By shining a spotlight on what this disorder is weakens its hold. OCD's strengths lie primarily in its ability to disguise itself. It often convinces the sufferer to take obsessions at face value, adapt to the individual's given surroundings, i.e. obsessions and compulsions frequently change over time, and the intensity of its presence, often leading to the perception of loss of control. It often strips the sufferer of all confidence, leading them to a state of vulnerability. And the experience can be so intense that the sufferer feels as if they've lost control. I'm here to say that even in severe cases, this is never the case. OCD may win many battles, but it never wins the war. The individual's will remains untouched. The severity of the illness only indicates the degree to which one's will is obstructed, but it's always there. Recognizing the gap between what one is and the disorder one has is the first step towards cure. With that in mind, I'll first address the definition of OCD. First in the form of diagnostic criteria, and then dive straight into the psychology, philosophy, and both the established and new treatments. There really is not enough information on OCD. Most of it is generic, and even doctors often lack in their understanding of it. Patients tend to seek treatment from 3 to 4 doctors and spend an average of 9 years in treatment before a correct diagnosis is made. The average amount of time that lapses between onset of symptoms and appropriate treatment is 17 years. And this is shocking, given that the prognosis is heavily reliant on catching the condition early, as well as the fact that obsessive-compulsive rituals feed themselves, getting more severe the longer they go unchallenged. Anyway, all of the information included in this video will equip you with all the information you need. So if you have OCD, you know somebody who does, or purely interested in advancing your knowledge of particular facets of the human mind, this is definitely for you. If taken in, I can confidently say you'll have a better understanding of this condition than, at the very least, 99% of the population. I'm Harry, your host, a doctor in psychiatry, a psychotherapist, and philosophy enthusiast. So, in my opinion, the most comprehensive criteria for diagnosis is in the new DSM, the DSM-5-TR. The criteria in this diagnostic manual state a diagnosis is made on the following presentation. First, presence of obsessions, compulsions, or both, and obsessions are defined by recurrent and persistent thoughts, urges, or images that are experienced. They're intrusive and unwanted, and to most individuals cause marked anxiety or distress. And the individual attempts to ignore or suppress these thoughts, urges, or images, or to neutralize them with some other thought or action, i.e. performing the compulsion. So compulsions are defined by repetitive behaviors that the individual feels driven to perform in response to an obsession or according to rules that must be applied rigidly. And the behaviors or mental acts are aimed at preventing or reducing anxiety or distress, or preventing some dreaded event or situation. However, these behaviors or mental acts are not connected in any realistic way with what they are designed to neutralize or prevent, or they are clearly excessive. And secondly, the obsessions or compulsions are time consuming. For example, more than 1 hour a day is what they state, or cause clinically significant distress or impairment in social, occupational, or otherwise important areas of functioning. Thirdly, the obsessive-compulsive symptoms are not attributable to physiological effects of a substance or another medical condition. And fourthly, the disturbance is not better explained by the symptoms of another mental disorder. The main one I would say is actually personality type. Now, multiple personality types can, on the surface, dispose to a similar presentation, the main one obviously being obsessive-compulsive personality disorder. The main factor that differentiates between the OCPD and OCD is that OCPD is a personality disorder and therefore referred to as egosyntonic, meaning it aligns with their personality type, and so the main features of this disorder, being that of perfectionism and inflexibility, are seen by the individual as being appropriate and correct. And this need for control can be distressing, but there's often much greater associated anxiety with the compulsions associated with OCD. And on top of this, the various manifestations of thought and behavior with the individual with actual OCD, well, these intrusive thoughts and rituals, they don't align with what they know to be reasonable, which often causes them even more pain. So in other words, it's what is referred to clinically as ego-dystonic. It does not align with their personality. The thoughts truly feel like intrusions, and the obsessive-compulsive loop experience often feels overwhelming. Something as trivial as checking a switch can give rise to, amongst other things, extreme autonomic arousal. The muscles contract, heartbeat increases, a state of fear, which often stems from a lack of trust, as well as commonly the feeling of embarrassment or self-criticism, as the insightful sufferer is often fully aware of engaging in these bizarre rituals. The time spent on performing compulsions in this heightened state of arousal can drive them into a state of exhaustion. It can be detrimental to their levels of contentment because often they are not engaged in activities that they believe to be meaningful. Instead, they are spending much of their waking hours engaged in activities that they know to be irrational and bring with it huge amounts of distress. Being that I'm already touching on it, I'll probably start with the psychology of this disorder. Experiencing obsessions and performing compulsions is an experience in which the individual feels strongly identified with the content of their mind. It can feel as if they are that mind. And as long as this is true, it's only logical to act in accordance with what it tells them, regardless of how irrational and often destructive it can be. However, one tool sufferers always have in their arsenal is the ability to discriminate truths. By nature, OCD is not a psychotic disorder, and sufferers are able to identify these intrusive thoughts as false. Obsessions can never take over a sufferer's will, and the disorder alone isn't capable of distorting the individual's ability to both accurately see it for what it is, or even control their responses to obsessions. What successful psychotherapeutic input does is it works on systematically identifying and challenging specific cognitive distortions. But like most endeavors in life actually, intellectual understanding is crucial, but it's not everything. Experiential understanding is what's also needed. No amount of rationalization will stop the occurrence of specific intrusive thoughts and the urge to fulfill the compulsion associated with them. Now, CBT is the most widely used psychotherapy for OCD. As the name suggests, it consists of a cognitive component and a behavioural component. And this behavioural component is delivered in the form of exposure response prevention, which very simply put is the systematic exposure to the individual's obsessive triggers without engaging in the compulsive responses. Now, the elements to both the cognitive and behavioural components are not exclusive to cognitive behavioural therapy. Other therapies overlap considerably in the techniques and approaches that they offer. But for simplicity, I'm going to largely explain the psychotherapeutic process from the cognitive behavioural perspective. So for clarity, let's split the process into the cognitive component and the behavioural component of the therapeutic process. The cognitive component largely entails, well, firstly going over an understanding of the disorder, much like I'm doing here. It will then go on to particular cognitive distortions that the individual may frequently adopt that exacerbates the symptoms. Cognitive distortions that are common for those with OCD are all or nothing thinking, overestimation of threat, catastrophizing, mental filtering, personalization and responsibility, perfectionism, and a big one is intolerance of uncertainty. Now, these are worked through often using techniques such as Socratic questioning. Using these techniques, the distortions are almost singled out and held under a microscope, and it often reveals to the individual how irrational these perspectives are and the amount of assumptions that, well, we all make automatically on an almost continual basis. This forms the basis of cognitive restructuring and the development of alternative perspectives. In cognitive therapy, these distortions are largely referred to as automatic thoughts. Automatic thoughts are surface-level assumptions, common to all of us, that they're not integral to our personality, but often flavor our perception of the present moment experience. They aren't held deeply though, so they're very receptive to change. Core beliefs that the individuals hold is then often also explored. These are deep-seated beliefs that we all hold about the way we see ourselves and others around us. As I've said, OCD is entirely separate from the personality of the individual. But that's not to say that there aren't certain core beliefs the individual possesses that is integral to their personality, which aligns with or exacerbates the obsessive thoughts and compulsive urges. These may include beliefs about oneself, the world, and others that contribute to the overall sense of vulnerability, or even a distinct lack of trust that they have for the world around them that may contribute to their intolerability for uncertainty and subsequent need for control. What's also useful to introduce in the cognitive component to therapy is the use of mindfulness and detachment techniques. Mindfulness, in my opinion, is one of them phrases that is seriously overused to the point that its definition has been diluted. As simply put, mindfulness is just the practice of intentionally bringing one's awareness to the present moment without judgment. And when someone is not in this state, it's very hard to differentiate their internal states, i.e. thoughts and emotions, from reality. In being truly mindful though, a person distances themselves from the content of their mind. They're observing their internal state, but they don't identify with it. This is obviously incredibly useful for all of us and can be incredibly useful as a skill for those with OCD, because it creates a gap between themselves and the intrusive thoughts that occupy their mind. As the ability to be mindful develops, the perceived gap between the rational self and intrusive thoughts grows. Over time, the individual can begin to shift from the what if that OCD lives in to what is, present moment reality. Now, to me, the cognitive aspect, when done well, is not just the cognitive appraisal, but it's then utilizing that individual's understanding to emphasize and bring back to the fore their will, as this then provides the motivation on their part which is needed to overcome what is an incredibly demanding but entirely achievable task of riding out the urges to give in to their OCD when exposed to obsessive triggers. So next up, and I would say most importantly, the behavioural component. I've previously mentioned intellectualization alone is not enough to eradicate the fear response that arises when obsessions that have been reinforced by completing the associated compulsions for so long. I'll spend a minute or so touching on the neurological mechanisms at play here, because I think it's useful to appreciate why the behavioural component is just so effective. So OCD is associated with a disruption in the cortico-striato-thalamo-cortical loop, a key brain circuit involved in the regulation of emotions, behaviours and cognitive functions. The loop is named after the regions it ties together. You don't need to be caught up with the names, it's really not essential, but for the sake of just being thorough, the cortico part refers to cortex. The areas of the cortex connected to this loop are the orbitofrontal cortex, which is located behind the forehead and involved in decision making, and the anterior cingulate cortex, which is situated near the middle of the brain above the two hemispheres and is crucial for emotion and attention. Striato refers to the striatum, a structure deep within the brain, and it's important for planning movements and motivation. Thalamo refers to the thalamus at the brain center, just above the brain stem, and this acts as a relay for sensory and motor signals. The loop connecting these regions supports the processing and regulation of emotions, decisions and behaviors, and integrating information from each region. The disruption of this loop for those with OCD is caused by an imbalance in the loop's direct, excitatory, and indirect, inhibitory pathways. In OCD, the direct pathway is overly dominant and the indirect pathway is underactive. This causes an excessive activity within regions connected by this loop. So in essence, the loop continues to fire when it should have otherwise turned off. The continuous activity within the loop explains the persistent obsessions and compulsions experienced by those with OCD. Despite acting on these obsessions, individuals often feel a sense of incompleteness, as the glitch in the loop signals that the task remains unfinished, compelling them to repeat the action. In a sense, the cortico-striato-thalamo-cortical loop helps us understand why individuals with obsessive-compulsive disorder tend to give prolonged conscious attention to information that should typically be processed automatically. Also characteristic of OCD is an excessive anxiety and fear associated with these rituals, things that most of us would deem completely harmless. The associated fear response can be better understood when looking at research findings that point to increased activation of a region of the brain known as the amygdala in those with OCD. The amygdala, when active, is central to promoting states of anxiety and fear. In neuroimaging studies for subjects with OCD, when exposed to obsessive triggers, there's an increase in activity of not only the loop that I described, but this is also accompanied by excessive activity in the amygdala. The functional connection between this loop and the amygdala is not well understood for those with OCD. What we do know though is that for non-affected individuals, the prefrontal cortex is able to effectively inhibit any unwarranted activity in the amygdala when exposed to unharmful stimulus. Now, for those with anxiety disorders, anxiety experienced is thought to be greater because the functional connectivity between the prefrontal cortex and the amygdala is slightly impaired, leading to less effective top-down inhibition and therefore comparatively excessive fear response. With OCD, strangely, these prefrontal cortical regions are excessively active at the same time the amygdala is. For those without OCD, what would normally follow from activities in these cortical regions is the suppression of activity in the amygdala and dampening of that fear response. Instead, with OCD, not only does the activity in both regions persist, The activity in both regions when exposed to various obsessive triggers actually correlate with each other. So i.e. the increased activity in the prefrontal cortex. With this, you also see increased activity in the amygdala and vice versa. So the main hypothesis is that for those with OCD, the prefrontal cortex, and just for clarity here, the prefrontal cortex that I'm speaking of encompasses those cortical regions I spoke of in that faulty loop that I described. So in those with OCD, the prefrontal cortex, instead of dampening the emotional response by inhibiting activation of the amygdala, as is the case with healthy subjects, it actually reinforces it, which explains why in OCD neuroimaging studies, both regions are seen to be excessively active at the same time. So we're getting into the weeds here a bit. If what I described just then seems like a bit of a blur, that's fine. The understanding of the specifics don't really have any practical implications. What does though is simply the recognition of the existence of a specific neural loop and its connected brain regions. This loop becomes excessively active, initiating the cycle of obsessions in individuals with OCD. Now, due to a malfunction with this loop, engaging in compulsions, i.e. actions taken in response to obsessions, fails to deactivate the loop as expected. As a result, this leads to a repetitive cycle of compulsive behavior. On top of this, the intense fear associated with these obsessions, often disproportionate to the actual risk or harm, can be best explained by the way this malfunctioning loop interacts with brain regions associated with processing fear. This understanding helps then explain why the behavioural component to therapy for OCD becomes so important. So in the treatment of OCD, the crux of the issue lies in the reinforcement loop and the association with fear processing. The process is deeply rooted in the brain's conditioning mechanisms. When an individual with OCD responds to an obsessive thought by engaging in a compulsion, this action temporarily alleviates the associated anxiety. Now, this brief moment of relief, it comes with consequence because it serves as a powerful reinforcement signal to the brain, strengthening the learned association between the obsession, i.e. the trigger, and the compulsion, i.e. the response. This conditioning ensures that the compulsion becomes the brain's go-to method for reducing distress, further entrenching the cycle of OCD. So with each act of the compulsion, it may provide immediate relief, but at the same time it also reinforces that such actions are necessary to manage or prevent the feared outcomes of obsessions, solidifying and strengthening the connections of this maladaptive loop. Exposure and response prevention leverages this very mechanism of conditioning, but in reverse, and it uses this to treat OCD effectively. Exposure and response prevention is pivotal because it's the only thing that addresses these learned associations directly, offering a pathway to rewire the brain's response to fear and anxiety. The process of repeatedly facing obsessions without engaging compulsions provides direct experience that challenges and ultimately changes these deep-seated neural associations. This direct confrontation with fear, without the escape route of compulsive behavior, is essential because it's the only experience that directly counters the learned association that obsessions must lead to compulsions for relief. Intellectual understanding of OCD and its mechanisms, while important for context, cannot alone weaken the conditioned responses because they're so deeply embedded within the automatic and subconscious parts of the brain that regulate fear and attention. Now, this rationale behind the necessity of direct exposure lies in the nature of conditioning itself. And just as the brain has learned to associate obsessions with compulsive relief, it can also learn to dissociate through new experiences. The experience of enduring anxiety without compulsive actions demonstrates that the feared consequences do not materialize, and the anxiety itself is tolerable and it's temporary. Now, this real-world experiential learning is crucial, because at this point it's the only thing that can directly alter the brain's conditioning by modifying the faulty wiring and learned associations at the core of this disorder. And this is not to say that it's straightforward. It's incredibly challenging for the sufferer. When a particular obsession is so deeply embedded, specific techniques that relate to exposure response prevention, such as graded exposure, can be very helpful. So next I'm going to touch on the established medication. So the first line treatment, which has been the case for a considerable amount of time, are the SSRIs, that's selective serotonin reuptake inhibitors. They're better than nothing. That's to say that across the board, the research shows that SSRIs currently licensed in the treatment for OCD all show that they are more effective than the placebo, so i.e. more effective than those not taking them. But those that respond, which is roughly 60% of individuals, a response in these trials, to be clear, is not cure. In fact, far from it. Historic studies typically define a response as only a 25 to 35% improvement in the Yale-Brown Obsessive-Compulsive Scale score. That is to say, only 25 to 35% reduction in symptom severity. So yeah, far from a cure. However, on a more positive note, 60 years prior, where exposure prevention therapy and antidepressants weren't around, the picture for sufferers was no doubt far worse. So it's fair to say that we can be grateful for the options that are now available, but at the same time, understanding that there's a lot more progress to be made. In brief, the antidepressants that are licensed all show a broadly similar effectiveness. There's not one particular one that stands out as being significantly better than the other. They do vary, however, in side effect profile. To explain the individual differences would require me to go into depth into the various subtypes of serotonin receptors, the complex interplay between these and different medications, which is, it's not the topic for today, but it is relevant in that primarily the main prescribers of antidepressants will be, at least in the UK, primary care doctors, who understandably aren't likely to know the specifics of the differing side effect profiles between different SSRIs, especially being that most treatment guidelines lump side effects of SSRIs as a class together. If experiencing intolerable side effects of a particular SSRI, it's still likely that another doesn't trigger such side effects. If you're not getting far with your primary care doctor in relation to these nuances, I would consult a specialist about this. For those that have trialed various antidepressants with no luck, the recommendation currently is to combine an antidepressant with an atypical antipsychotic. The two that have demonstrated some effectiveness in these circumstances are aripiprazole and risperidone. So now moving on to the extra knowledge beyond that which is relatively well known. I'm now going to go into specifics helpful to know when optimizing OCD pharmacotherapy. That is dosing, new treatments involving different physiological mechanisms, as well as some evidence-backed supplementation. I'm going to categorize the following based on the main proposed mechanisms of action of these various medications and supplements. So first off, the serotonergic system. Obviously, I've already touched on antidepressants, being that of SSRIs. High-dose SSRI treatment, doses that are higher than the upper boundaries licensed for typical use in multiple studies, have shown to be significantly more effective in relieving symptoms of OCD than the typical medium dosing protocol. However, the predictable concerns being mainly that of an increased dropout due to increased side effects was shown. That being said though, to most, these higher doses were still generally tolerable. Next, Ondansetron. This is augmented with a normal SSRI. This is an interesting one. Ondansetron is best known to be used for nausea, but it works largely via its effect on the serotonin system. Now, out of all the trials, there is generally an improvement when compared to SSRI alone, when combining it with an SSRI, and it was generally very well tolerated. Interestingly, 2 RCT studies, so randomized control studies from Iran, showed the combination of Ondansetron and SSRIs showed a dramatic decrease in symptoms of OCD in comparison to the group receiving SSRIs alone. For various reasons, these studies have been criticized, but generally, being RCTs and the drastic improvements seen in results, they're useful to take note of and definitely prompt further investigation. Next, this is getting quite a lot of talk at the moment for various reasons, but psilocybin. This is something I've covered previously in depth in regards to depression, as it's showing real promise with that. The need, I think, to explore it with other mood disorders, and I think which has prompted the exploration of it with other mood disorders, or at least persistent emotional disturbance, comes from the mechanisms of actions in which it works in depression, namely its effect on altering connectivity in regions known to be associated with excessive self-referential thinking, in other words, overthinking. Now, the promise in my view that psilocybin might have with OCD, it doesn't come from the results to date. Although very few studies have been done so far, the results are largely mixed in regards to psilocybin and the symptom reduction seen for those with OCD. There are many anecdotal reports of the benefits psilocybin has with OCD, but again, that's weak. The main driver, from what it seems, is looking at how psilocybin has been proven to alter connectivity in certain regions that I previously discussed are implicated in OCD. Now, with psilocybin, its primary mechanism of action involves binding to serotonin 2A receptors. The process central to its proposed success in treating depression is based on these receptors' interactions with regions associated with depression. This is notably the default mode network and the various cortical areas that are connected to it. Now, following acute psilocybin ingestion, these regions undergo functional alterations, but the more enduring effects are believed to stem from the permanent rewiring of these dysfunctionally operating networks. The potential application of psilocybin in treating obsessive-compulsive disorder draws on a similar rationale. Just as with the DMN, default mode network, in depression, The serotonin 2A receptors targeted by psilocybin are also densely located along the loop that I spoke about earlier, the corticostriato-thalamocortical loop. Now, altered functioning within this loop is observed after psilocybin ingestion, which suggests a potential therapeutic possibility like in depression. The hope, but which is yet to be fully realized or observed in studies as it stands, is that leveraging this altered state and subsequent period of heightened neuroplasticity could facilitate lasting improvements in OCD symptoms. But obviously things are not that simple. That is theory of how something could work versus the reality of whether it does, are two completely different things. But I guess deciding to do research on anything, it always starts with a credible theory. So yeah, the potential role psilocybin may have is certainly worth studying further. Next off, we've got dopamine and noradrenaline. Now, since the 1980s, there have been a number of studies looking at the potential role of psychostimulants, either as standalone treatments or in conjunction with the serotonin reuptake inhibitors for patients with treatment-resistant obsessive-compulsive disorder. The double-blind controlled studies that have been done have generally shown positive results, especially a more recent one done with the stimulant methylphenidate and a combination of an SSRI. Given the risk of misuse associated with these substances, their use in treatment obviously requires a lot of careful consideration. Now, the notion that stimulants could aid in the management of OCD initially appears paradoxical. Now, while ADHD, a disorder that readily improves with stimulants, with ADHD, with this, you see a reduced activity in the frontal striatal brain regions. This reduced activity of the frontal cortex in ADHD is associated with the diminished executive functions such as attention regulation, impulse control, and planning. Now, this underactivity leads to the core symptoms of ADHD, including inattention, hyperactivity, and impulsivity. OCD is categorized by an enhanced activity in these areas, and so lies at the opposite end of the compulsivity-impulsivity spectrum. But despite these differences, both disorders share certain executive function impairments, such as response inhibition, attention allocation, and cognitive set shifting. Now, this overlap may hint at a common underlying pathophysiology. These shared deficits in OCD might plausibly explain the positive response seen to stimulant medications in studies. Also, disrupted dopamine signaling throughout the malfunctioning loop is seen with those with OCD. So, like all of these pretty messy brain studies, you really can't look at any one thing in isolation. It's just so complicated. But clinically, the individuals with OCD who found relief through stimulants in these studies reported a decrease in the preoccupation with intrusive thoughts and improved focus on activities unrelated to OCD, an effect similar to that reported by those with ADHD. Now, stimulation and focus are two different things. Stimulation in general implies just an indiscriminate arousal of everything. But focus, this involves arousal that I guess is targeted. So with that, you have to presume there's a large amount of inhibitory control and discipline needed in these states in order to keep that focus narrow and almost channel that energy. So when someone responds to psychostimulants in a way that they report to be more focused and less distracted, well, it's reasonable to suggest that there's a stimulation of certain inhibitory pathways too. For example, caffeine has recently been shown to alleviate distress and compulsive cleaning urges in individuals with high contamination fears. And this effect was seen in this experiment to reflect the beneficial impact that caffeine has on not just excitatory stimulation, but also inhibitory control. With all that being said, these studies so far on the use of psychostimulants are few and far between. Not only that, but there have been ample case reports of either stimulants inducing obsessive-compulsive rituals in otherwise healthy subjects, or making the obsessive-compulsive rituals worse, which also makes sense. If the stimulation is indiscriminate, then it's healthy to assume that it's likely to amplify stress and fixation on particular rituals and individuals engaged in. But it's definitely an avenue of research that would be great to look into given some of the promising results, but far from a plausible treatment as it stands. So next we're going to go over glutamate. So glutamate, like with other mood disorders, is subject to a lot of attention now for OCD. The various medications that affect glutamate transmission are used more traditionally for neurodegenerative diseases such as Alzheimer's. They show mixed improvements for those with OCD. However, because of the growing understanding that glutamate transmission has in the pathology of OCD, a number of studies are currently underway in regards to these agents to find out slightly more about their potential benefits. Another medication known for its glutamate signaling is pregabalin, and the few studies done generally suggest that this can be beneficial for OCD, especially when combined with an antidepressant. But like stimulants, this can be highly addictive, and so the results from my perspective would need to be considerable for it to be a feasible treatment option. And then when we get into the anti-inflammatory and opioid modulators, there's probably more to say for this in regards to the supplement section, which I'll go on to next. But Both anti-inflammatory, opioid and cannabinoid agents are being investigated at the moment for use in OCD. Again, mixed results to date, so little to go by at this point. So a big one from my perspective is nutrition and deficiencies, because this is something that you can do yourself, and something that's often overlooked, but often the simplest way to alleviate some of the symptoms. This is always a neglected aspect when considering mental health disorders, but when compounded, they can have considerable effects. So I'm going to list these off quite quickly. First, N-acetylcysteine, otherwise known as NAC. This is an amino acid-based nutraceutical which has found to modify the release of glutamate, a neurotransmitter known to be dysregulated in those with OCD. Its effects, although mild, are most promising when used as an adjunctive treatment to the typical antidepressants licensed. Doses given in studies usually range from 2,000 milligrams to 3,000 milligrams daily. The adverse effects are rare, and it can be used in conjunction with typical antidepressants. Next, borage. So borage is a herbal plant known for its medicinal properties. One study so far has been performed. It evaluated the effectiveness of a 6-week supplementation of borage at the dose of 500 milligrams a day compared to a placebo in treating 44 patients with OCD. The findings revealed a significant reduction in Y-box scores, so i.e. OCD symptom severity, and Hamilton Anxiety Rating Scale scores in participants taking borage at both the 4-week and 6-week marks. By week 6, the Y-box scores and the Anxiety Rating Scale scores had decreased by 6 and 10 points from baseline respectively. There were no significant differences between the treatment groups regarding adverse effects. Next, milk thistle. So milk thistle is thought to have immune modulatory, anti-inflammatory and neuromodulatory effects. One randomized controlled trial has been performed so far. This trial, lasting 8 weeks, involved comparing treatment with fluoxetine to treatment with milk thistle, and this was a capsule of the extract dosed at 600 milligrams daily. Both showed similar results in terms of efficacy in reducing symptom scores for OCD, demonstrating that milk thistle was as effective as the antidepressant in treating OCD. Much more research is therefore needed to further ascertain its potential therapeutic effect. Next, valerian root. Only one randomized controlled trial has been conducted looking at the effects of valerian root on subjects with OCD. It showed modest improvements in symptoms over the course of the 56-day study for subjects receiving capsules of the extract, and this was capsules of 765 milligrams daily compared to the placebo group. The results obviously indicate that valerian root may have a positive effect on alleviating OCD symptoms. Next, vitamin B and homocysteine. So vitamin B6, folate, otherwise known as vitamin B9, and vitamin B12 deficiencies have all been associated with those suffering from OCD. Studies have also replicated the observation that individuals with OCD appear to have high levels of homocysteine. This is an amino acid which, when elevated, is associated with long-term cardiovascular risk, as well as detrimental effects on cognition and mental health. Although studies investigating the supplementation of folate, i.e. vitamin B9, vitamin B6 and vitamin B12 have not demonstrated efficacy in reducing symptoms for those with OCD, the abnormalities in these levels are associated with symptom severity. So therefore, regardless of the results so far, I'd always advise that the correction of these levels is paramount to good health, and the supplementation of vitamin B, specifically vitamin B6, B9 and B12, well, it's essential if these deficiencies, which are more common in OCD, are present. Not only this, but the supplementation of these particular vitamins will work to lower levels of homocysteine if elevated, as it's often the deficiency in these vitamins which is responsible for the rising levels of homocysteine. And a quick note, if supplementing with vitamin B9, i.e. folate, it's safer to use the bioactive methylated form, known as 5-MTHF. This is because it's common to possess a gene mutation that affects the conversion of synthetic folic acid. So to ensure safety for those without access to blood testing, supplementing with 5-MTHF instead of the commonly used folic acid, well, this would be the most sensible option. Next, vitamin C and vitamin E. Although no clinical trials have investigated the effect of vitamin C and E supplementation on OCD, it's clear that the deficiencies in these vitamins are associated with the condition. Therefore, it makes intuitive sense that a targeted assessment of these levels, followed by their correction, would be appropriate for potential symptom reduction. So next, a quick note on trace elements. So in addition to the abnormalities in various vitamins associated with OCD, there also appears to be an imbalance in trace elements. OCD is linked with deficiencies in selenium, zinc, iron, and magnesium concentrations, as well as abnormally high levels of serum manganese and calcium. While there are currently no studies specifically examining the effect of magnesium or iron supplementation on symptom reduction for those with OCD, research has been conducted on the other elements mentioned, which I'll now describe. So first, zinc. Zinc supplementation, as shown in a few studies to date, has demonstrated efficacy in reducing OCD symptoms. One randomized control trial conducted over a course of 8 weeks compared two groups, one group taking fluoxetine at 20 mg daily plus zinc sulfate at 440 mg daily, and another group just taking the fluoxetine 20 mg daily plus a placebo. The results revealed that the group receiving the additional zinc supplementation experienced a greater reduction in symptom severity compared to the group taking fluoxetine alone. Next, selenium. So one study has been performed so far, evaluating its effects for those with OCD. This randomized placebo-controlled study involved 30 patients with treatment-resistant OCD. These patients were divided into two equal groups. One group received a selective serotonin reuptake inhibitor along with the selenium at 200 micrograms daily, while the other group received an SSRI with a placebo. After 6 weeks, the group receiving selenium showed a significant reduction in white box scores, i.e. symptom severity, compared to the placebo group, with no notable side effects. So moving on, inositol. Now, the investigation of inositol as a treatment for OCD is interesting. It's believed to act by altering the serotonin system, specifically by increasing serotonin receptor sensitivity. Now, the evidence base is somewhat mixed. Positive results have been observed in subjects with OCD taking large doses of inositol, specifically 18 grams, administered alone without adjunctive treatment. In the two studies using this dosing protocol, subjects reported significant improvements in symptoms after 6 weeks. The second study also correlated this symptom reduction with decreased cerebral perfusion in areas known to be associated with the pathophysiology of OCD. And more research is needed as the doses trialled are very high, and symptom reduction has not been replicated in studies investigating its effects when used in combination with other treatments. Next, ashwagandha. So ashwagandha is a well-known herbal supplement often used for its calming effects. Only one study has been performed so far looking into its effects on OCD. Now, this was another RCT which compared two groups, one taking an antidepressant alone and another taking both an antidepressant and ashwagandha. After a 6-week trial period, the group receiving both ashwagandha and the antidepressant showed a significant reduction in symptoms. The study involved the subjects taking 120 milligrams daily of this particular root extract. Given the limited number of studies on this subject, obviously further research is warranted, but again, promising results to date. Next, saffron. Now, to date, there's only been one clinical study examining the effects of saffron on OCD. This study demonstrated that saffron supplementation at 30 milligrams daily is as effective as the SSRI fluvoxamine in reducing symptoms after a 10-week trial period, although both effects were mild. Lastly, there's sarcosine. So sarcosine, a natural supplement that inhibits glycine uptake, has been the subject of one study to date. This study administered a flexible dosage schedule of sarcosine from 500 to 2000 milligrams daily to the subjects with OCD. Participants were divided into 3 groups, so first group being drug-naive individuals, the second being those who had stopped taking an antidepressant at least 8 weeks prior, and the third included those taking an antidepressant concurrently. All groups showed a modest improvement in symptoms after the 10-week trial period, and these effects were noted very early on. It's important to note, as with any supplement or medication, it's always crucial to consult with the appropriate clinician before considering starting any of these. This video is merely an overview of the evidence to date, aiming to inform the wider audience. So lastly, wrapping up, I would say that over 50% of the progress can be made outside of the tailored treatment approaches. Things that aren't specific to OCD, but they certainly go a long way at further reducing symptoms. Take exercise. For those who generally find themselves with a baseline level of anxiety, activity in any form is indispensable. I came across this quote recently which resonated with me. It was by a man named Thucydides. The quote was, "The society that separates its scholars from its warriors will have its thinking done by cowards and its fighting done by fools." There isn't really a need for most of us to regularly exercise, in the sense that it isn't a necessity for most of our daily requirements. But there's no doubt that it's a necessity for our mind. I think that when we separate the state of our body and mind, we make the first mistake. Every single form of emotional disturbance, being anxiety, fear, anger, sadness, it manifests itself not just psychologically, but physiologically as well. Engaging our body is far from being purely a distraction. It's a large part of the solution. I find that a lot of individuals who have OCD and have made a significant amount of progress, not one of them would report it being easy. But as is the case with most periods of significant adversity, it's also an inescapable way of learning a huge amount about yourself and others in an incredibly short amount of time. Because the lessons that you learn and obstacles you need to overcome when living with OCD, a lot of them are applicable to challenges outside of it that you'll inevitably have to face. The basic premise behind transformation is applicable to most other things, and it's a theme that runs not only through our understanding of science, but actually much before that. That is, periods of growth almost always involve the voluntary descent before ascent. And many disciplines will speak of this in different ways. Existential philosophy speaks of embracing the absurd. This was a fundamental principle of Stoic philosophy. For instance, Seneca famously said, "Fire tests gold, suffering tests brave men." Jung would speak of the process of individuation and integration of the shadow. Or common in religious texts is this idea of death and rebirth. In simpler terms, what this term voluntary descent before ascent really means is appreciating that for healing and transformation to occur, what is often inescapable first is a period of pain and even temporary regression before growth is possible. The confrontation of these internal obstacles is painful, but it's necessary for change. With OCD, for this to be beneficial, the confrontation has to be voluntary. When the individual is passively subjected to obsessions, it won't work. Voluntarily confronting obsessions, and really any fear, shifts control to the individual. By going out their way to face the triggers head on, there's an instant shift in the power dynamic, and the focus moves from trying to control the existence of these thoughts to controlling the response to them. And when the personal choice is made to navigate through psychological discomfort, it signals the shift from a position of victimhood to a position of strength and self-direction. I started this off with the appreciation that OCD may win many battles, but it never wins the war. I'll finish it off with adding that during the voluntary confrontation of obsessions, you get to pick the terrain. And over time, I can promise the battles become few and far between. Anyway, guys, I hope this episode has been of some help. Please subscribe and provide a rating if so. I'm open to suggestions as well as to what I cover in the future, and any questions about the material I've covered. As always, don't hesitate to ask. Thanks for listening.